The fear goes away pretty quickly. My kids love to crawl in bed with me and talk about business. So my goal is to disrupt an industry, as lofty as it sounds. I wanted women to feel safe. I wanted them to undergo one of the most vulnerable moments of their life. Maternal mental health is one of the most expensive global problems that we have.
My guest today makes life and death decision in a delivery room. Then she goes home and runs a medical device startup. Welcome back to the conversation with Florid. My guest today is someone who I think represents the exactly kind of people this show was built to talk to. Meagan Furnivall. Meagan Furnivall is a registered midwife and citywide lead for London Health Sciences Centre. She is a professor at both McMaster and Western University and only one in Ontario leading this industry, and she also serves as Ontario site lead for JEPS Hub, which is Justice and Equity in Perinatal Service. She is also a founder of Revara Care, a company developing birth gown, which is patent medical device to improve the experience of birth for mothers, babies, and healthcare providers worldwide. She has spent 15 years in a delivery room in a clinical setting, taking those high-stake decisions. And then she took everything from what she has learned, channelized it into building something all from scratch, with no business degree, no roadmap, and no guarantee even if it would work. She's the proof that people closest to the problem are usually the ones best equipped to solve it. Meagan Furnivall is one of those examples. Let's get into it. Meagan, so let's start with what is midwifery?
Okay, so midwifery it's a regulated health profession. So midwives are trained, we go to university, we do a 4-year degree here in Canada. And essentially what we do is we take care of women who have low risk pregnancies and births. So that means women who do not have a lot of complications at the beginning. Sometimes things get more complicated and we consult with our obstetrical colleagues or physician colleagues. But essentially we're responsible for all the prenatal care and then the birth. We go to the birth, we deliver babies with these families. And then we watch and take care of the mom and the birthing person and their baby in the first 6 weeks. So we're responsible for both of them. So we do the delivery, we do, I'll order all the ultrasounds, the lab tests, the blood work, and same as a physician would. And then if anything complicated comes up, we tap in our colleagues for help if we need them.
Wow, such a noble and humble profession.
It's
to
a
be
beautiful profession. It is, yeah.
What is something they need to do before, during, and after the pregnancy? Based on your experience, what you have seen, some things that's not enough told about.
Women are really struggling right now. And it's because they want information. And we're living in a world where you can get a lot of information all the time. You're bombarded with it. The quality of the information isn't always great. There's a lot of misinformation. So I think when you talk about what women need that they're not getting, we need to be able to give them either more time as clinicians, which we don't have. A lot of times we just have, midwives have longer appointments, but physicians are tasked with high volumes of patients. So they need more time, they need more answers. They need better quality information. And yeah, I don't really have an answer of what I could say would be a quick answer to that. There are companies trying to come up with those solutions. But what women really need right now is they need a relationship in some capacity with the person that's going to be on this journey with them. And access to good quality information. Because if you don't have good quality information, they get scared. They hear terrible stories about birth and they're afraid. And so when you can sit with them and build that relationship and teach them about what's coming, then the fear goes away pretty quickly. And then they can actually focus on having a beautiful experience instead of all the scary things they hear about on social media.
You have spent 15 years watching people delivering babies, how system handles the birth. What would be that one thing that makes you completely rethink the entire system?
Yeah, I think that's a great question. It brings me to my startup work, which I know we'll talk about later, but I think for 15 years in my training, dating back 20 years, I was so confused. It's the reason why I went in to be a midwife, was I couldn't believe the stories I was hearing about how women were being treated. And it didn't make any logical sense to me. And so I went into midwifery because I wanted women to feel safe. I wanted them to undergo one of the most vulnerable moments of their life in a space where they felt like the people in that space were there to protect them. And the stories I was hearing, that wasn't the case. And so watching over my career, I kept seeing the same thing. I kept seeing women often naked or half naked, some of them by choice. Some of them were very happy to be naked because birth is a complicated endeavor. And I used to dry so many tears from women just feeling on display and feeling like they were out of control. 12 strangers in the room, to deliver babies. It just seemed it just didn't seem like it needed to be that way. We didn't need to have women exposed. It was dignity, essentially. And dignity shows up in many ways. It shows up in physical dignity. How do we make you feel like a human being and not naked and on display as an object? And we do that across healthcare in general, but in women in birth, it's particularly problematic. So dignity, physical dignity, always felt compromised to me, and sometimes for good reason and sometimes really unnecessarily. And then I would sit with women after births and in their living rooms, over 1,000 births, and listen to their stories about how that experience made them feel and the damage that experience would cause. And as a midwife, you're one of the very few clinicians, if not the only clinician, that gets to be at the birth, watch that baby be born, and then talk to her about it multiple times afterwards. Usually as a physician, you might deliver the baby and then you see them a couple weeks later and then a couple weeks after that. But there is a lot to unpack after that. So dignity was always it was just never prioritized. And I saw the damage that came from that. That was, and then the way that we show up. So my research, I studied this in my research. The way we show up as clinicians and sit in that space with women in pregnancy and birth is so important. And I kept seeing people showing up and not prioritizing that. And so women's questions wouldn't get answered. They would feel like they weren't a priority. And then for a long time in our culture, we think it's because clinicians are the problem. And so it would be a kind of an argument between the patient and the clinician. The clinician doesn't listen, and the patient's too needy. The patient is asking for too many things. And what I realized was that actually the way we provide care, the way it's set up, is the problem. The clinicians are busy. They're trying really hard to meet demands, and it's very difficult. And I can say that because I am one, and I know what that feels like. But also as a patient, having been a patient, dignity is one of the most overlooked aspects of patient care. And when we prioritize it, because in 15 years, I got to see what it looks like when we didn't prioritize it, and I got to see what it looked like when we did. And when we did, the outcomes were very different. And that's not even including the women who want culturally appropriate care, who want more coverage. Their dignity is extra important to them and their partners. So when we would prioritize these things, you would see a very whole, healed mother in the postpartum. She didn't have the same flashbacks. She didn't have the same problems. She was reporting very different experiences. She could have a birth that was so off of what she wanted. She could have wanted a beautiful, straightforward, normal birth and then ended up in the operating room for a C-section, like opposite. And if you protected her dignity when you could, and you treated her like a human being, and you talked to her and you made her feel safe, she was very different after. She would say, it didn't go the way that I wanted it to, but you know what? I'm okay with that. Because I never felt scared in the same way. So there was something about dignity that I was seeing over time, and I got to experiment with it. I got to that was the first piece, was the dignity piece. The second piece is that women were telling me over and over again, when the baby's born, I just want to hold my baby on my chest. And we would go into vaginal births, and there'd be posters all over the wall. Skin to skin contact with your baby is the most important thing you could do. And then we would go to the operating room, and suddenly we would say, yeah, maybe we're going to do it. We don't know. We're going to see if we can. And morally and ethically, I struggled with that, because I knew that if we separated them and she couldn't hold the baby on her chest physically, it was a very different outcome. The attachment, the bonding, there was so much stuff that would be different. And I had a real problem with that. So I would end up arguing with the system over and over again. Why aren't we doing this? This doesn't make any sense. So dignity, that skin to skin contact between that part of my experience as a clinician in birth is integral. It's so foundational to good care, but we still don't offer it consistently.
Is there any of those experience live trauma to those
yes,
patients?
Hugely. It's part of the reason why I care so much about this work is maternal mental health is one of the most expensive global problems that we have. It's very nuanced. There's many dimensions to it. But when you have a birth that is traumatic for women, there are things you can do to make it worse, and there are things you can do to make it better and less traumatic. One of those things, according to the World Health Organization, is dignity, supporting women's autonomy and agency. Don't touch them when they don't want you to. Ask for permission. It's very basic human rights things.
Sure.
And the second piece is skin to skin. So when you put a baby on a chest, and I did this for 15 years, I experimented. We would have births where things were going kind of off side, like they were not going well. And so we would say, okay, we're in the operating room. We're not going to put the baby on the chest. It's too dangerous. But then the odd time we would. And I wanted to experiment with that, because what I learned through the research and through experience was that when you put a baby on the chest, even if it's like 5 minutes, there's something about the skin touching that it re-changes the neural pathways. So the way that the mom's brain fires changes. The neural pathways change. They fire differently and they wire differently. So bonding and attachment is better. And then the traumatic experience is not the same. So the memory changes. So now her memory is different. So you buffer it. So there's a protective aspect to that. So then we would do skin to skin. And then these women who would have it in the postpartum would not experience the same level of PTSD. So PTSD following childbirth isn't diagnostic criteria. It's in the DSM, but it's underreported because we don't measure it. We don't look for it. But when you use skin to skin, it's a huge intervention that reduces maternal mental health costs. It has so much potential to save the health system money and to reframe that postpartum experience for women and the partner.
Right, absolutely. What else is missing in women's health space?
Research. There's so much. So it's essentially over the last you could go back further, but over the last 150 years, women were excluded from research. This is known. We know this. We were never really prioritized. So when we talk about cardiac health, when we talk about, could be anything from dermatology to cardiology to obstetrics to urology, all of the departments of medicine, the areas of medicine, research was done on men, and then they never really looked at women. So they just assumed women were small men, and whatever the findings were for men would be similar for women. But we actually know now that that's not true. So the drugs that were created, the research that was done was not accurate. So we would give the same drugs to women in a slightly different dose, and it would cause harm. So in women's health is picking up speed now, because now we've identified that women are more sick than men. They have more autoimmune diseases than men. They suffer differently. Their symptoms are different. So now we're actually prioritizing that research, and we'll talk about it in Canada. There's work being done. But essentially, we need more funding We need more research,
Hmm.
and we need more women's health innovations. We need more VC funding. We need more prioritizing of the innovation on that side of things. We're sadly very behind.
Was this the reason how Revara Care started?
Yeah, Revara Care started for a few reasons. So when I was training as a clinician, learning as much as I could about women and families and birth, and then I knew I had my second child. So my second child, I was 8 months pregnant. Went out first thing in the morning, fell on black ice, spiral fractured my leg. So it was kind of an interesting coincidence, but first day of my maternity leave, was so excited to just clean my house and get everything done. I was like, I can't wait to get all these things done. 7:30 in the morning, down on the driveway, middle of winter, and nobody could hear me. I had to crawl up my driveway to get my husband's attention. The long and the short of it was, went in for surgery. I was hospitalized for 2 weeks, and nobody knew what to do with me. Like, the clinicians didn't know. They couldn't really give me the medication that needed to get my pain under control. My pain was not under control. Imagine having a metal rod put in your leg and then being given Tylenol and morphine, but I wasn't absorbing the dilaudid medication they were giving me. So every 4 hours, I would need another injection. And for 11 days, I was admitted for 11 days. It's supposed to be 3. And the obstetrical unit didn't want me on their unit because I was an orthopedic patient with a broken leg. I just happened to be pregnant. The orthopedic team didn't want me on their unit because I was pregnant, and they thought, we don't want a pregnant person on this unit. Luckily, my team, I knew the OB team, and they said, we'll take care of you on the OB unit. So they took me in and took care of me, and they really did an amazing job. But nobody knew what to do with me. Nobody knew how to structure my pain medication. I had the most wild questions from the pain team. And it was 11 days because there was not a lot of research on how to handle broken legs in pregnancy. And I remember as a patient, people didn't believe me. People thought that I was making up that I was experiencing pain because they just couldn't understand how they'd given me so much morphine and I still didn't have enough pain relief. And day 11, my mom walks in and she says, "Oh, I could never digest Dilaudid. When I had my babies, I could only digest morphine. It didn't work for me." And I said, "Oh my gosh, Mom, you think you could have told me that 11 days ago?" So they realized I was never absorbing the oral medication. So of course I wasn't getting pain relief. So the long and the short of it was, I went home. I had severe postpartum depression after that. I had a toddler that I had very little family support. My mom was there for a period of time and she was amazing, but I had to take care of this 3-year-old. I had a baby in a sling and that I would carry around as I would scoot around the kitchen with a broken leg. It was a disaster. But I realized I wasn't the clinician in that situation. I knew how bad it was as a clinician to try to provide dignity and listen to women and that standard of care they needed. But once I became the patient, it was very clear to me how these women must feel when they're not listened to, when they're telling you that they're in pain, and we're saying, "There's no way that you don't have pain relief. We've just given you all these narcotics." That experience really helped me understand that there was a whole bunch of work that needed to be done. And products, we didn't have the products. We go to the obstetrical ward, and if you walk down to the cardiology unit, you'll see robots doing surgery. If you go to the birth unit, the technology is 100 years old. There's no innovation. And so part of me was thinking, like, there's a huge gap here. I have all these ideas to create things that could address some of these problems that I personally experienced, but then also witnessed. And I thought, you know what, maybe I should just create them. So I got to work with building that company.
Right. So being a clinician, getting into a startup world without an actual business degree, what was the hardest, what would be that hard thing that you learned the hard way?
I didn't necessarily jump from clinician into entrepreneurship right away. I knew that I wanted to start this company, but I also knew that I needed to really understand how to create a change. Like, it's bigger than the company. It's how do you disrupt a system, right? Which is a bold statement to make. But how do you convince clinicians to change their behavior? How do you create technology in a space you've never created technology in? And how do you have the guts to go after it, right? Which is the part that took the longest. That part was the hardest part of my journey. So what I did was I said to my husband, I need to do my master's degree because I need to understand research. I need to understand how to do it, how to read it, how to articulate it. And I went and did my master's, did some work on how you sit with women and make decisions with them, which was fascinating. And then took a job in research. So all the while learning how to build a program of research at our hospital. And I led that team for a while. And then I went into health leadership. So it was right around the time that I had this idea. So I had this idea based on my research. The research really set the stage for the product. The product idea kind of dropped into my head one day. And I thought, well, dignity is an issue. Skin-to-skin contact is an issue. We're not able to do it. And then when I talked to the clinicians and asked them why, I learned all the reasons why. So I created a solution that would address those reasons and de-risk it. So I said to them, if I create this product and it addresses all of these issues, will you use it in the operating room? And they said, please, could you please do that? Because they want to show up and provide the best care to their patients. They really do. But when you don't have a mechanism to do it, you just can't. You're running from surgery to surgery to surgery. You can't take an extra 30 minutes to do the long way around to give them what they want. You have to just keep moving. So I had this idea to take this patient gown. So we have these patient gowns that we've been using since the dawn of time, and they're used in all areas of the hospital, but they're dysfunctional, they're undignified, and they're clinically useless. So I said, if I can re-engineer it, redesign it to be easier for me to use as a clinician, less disruptive to the patient, take all the feedback from the patients that I've received, create something that they want to wear that's useful. I always say it's like going to yoga in jeans. If you only ever went to yoga in jeans, if that's how yoga started, with jeans, and then I came in with other exercise wear, athletic wear, people will say, well, I don't understand why you're doing that. We always wear jeans. And that's kind of the sentiment. And I said, yeah, but like, could you imagine how much better birth could be if we actually had something we felt comfortable in and not on display? So I re-engineered it. And that has been a long process because I didn't know, how do you build a product?
Exactly.
Right? Like, how do you take an idea in your head and create it in real life, which I thought was maybe 10 steps. It turns out it's 1,000, right? So that's where the research kind of informed the idea. And then the idea sat in my head for a while until I had the guts to speak it out loud and to go after it. And that was the longest part. That took me the most time.
Right. The gown that currently they have,
Yes.
is it the one that's kind of blue color or green color where you tie on the back?
Yeah. Yes. Okay. Yes.
Awesome. Can you tell me more about the gown that you have designed?
Yeah. So the gown's designed to be used in all births. So essentially it's because the current gowns you put on and you tie them up at the back and then you wear a second one as a robe to cover your bum because your bum is usually exposed. So what we did was we designed a product that allows you to wear it in all births. So it would be ultimately, by the time we're done testing, Health Canada approved as a medical device, same with FDA in the United States. And so it's designed for us to be able to go into the OR with it, not having to take it off. And all the procedures in the operating room that we do, like a spinal epidural, we need to put monitors and leads on people. Those are all able to be put on and all those procedures are able to be done without actually having to expose the woman. So normally she lays down on the table and the gown comes up completely to be able to do that skin to skin. But our product allows us to actually remove steps from the clinician's workflow and provide that level of dignity, and then secure an infant to the chest in a way that's safe so that we can do skin to skin in all births. There's no reason that we can't, which was the goal.
Right. Were you always entrepreneurial?
I think so. I think I've always been a creative. I started a business on my maternity leave. Like, I think that's a bit of a tell when you're not supposed to be doing that. But yeah, I've always been a designer, I would say. I was in Chicago a couple weeks ago at the Institute of Design, and it felt like home. It felt like, oh, these are my people who can pattern recognize and take something and make something beautiful out of it. I've always been like that, whether it's my home or my family. But I never had the skill set. I never had anybody in my life to help me learn how to build. So I had to teach that and go find that.
What was the first big risk that you took?
The first big risk that I took, there's so many risks. Like, I think when you're building your life, I think it comes down to like creating your own life. What kind of risks do you want to take? I'm a risk taker, so it's a hard thing to say, but I would say believing in myself, like really pulling myself out of frontline clinical work was a big risk for me. It's an income. It's my life that I built. It's who I was, and that took me a long time to say, I'm not going to do this anymore in this way and just do full leadership and entrepreneurship. And although it feels like an obvious pivot, it was really hard for me because of the people that I served, the relationships that I built, the families. Like, women come back and they want you to deliver the next baby and the next baby, and you build those relationships. And I really struggled. So I actually just made the decision. I'm going to stop this part of my life, and I'm going to take a pay cut, and I'm going to go run. And I'm basically going to double down on me and what I think I can build and what I know I can build. So betting on myself, really actually, not just saying so, was the biggest risk I think I've taken so far.
Yeah. Usually the startups backed by 15 years of experience and leading in the same direction says a lot. So that absolutely makes sense, doubling down on your own self.
Well, that makes me feel better. Thank you.
Was there any turning back moment from the entire journey?
Oh my gosh, yeah. Well, I think there's moments every day where you ask yourself, what am I doing? Is this something? I think entrepreneurship, it's hard to leave a space when you've mastered a skill set, you're comfortable in that skill set, and then you want to go bigger or you want to take on more. And there's more risk and there's more uncertainty. And I think that every day for me is a challenge, but I think I've learned to work through those moments quicker. I've sort of told myself, it's okay if you're not sure. It's okay if you want to go back to your old life. But really, I have that vision. When you're an entrepreneur, you're somebody who has that gift where you can see the thing that you're trying to create. I just hold it. I hold it as much as I can so that I don't. And then I give myself space to rest and feel like, like I want to go back in time a little bit. But then I always just pick myself up and say, get back to work. You got stuff to do.
Right. You were in the room where life and death decisions were made, being in those clinical rooms. Does that clinical pressure help you in any way to handle the stress of running the company?
I think so. I think absolutely. I think you get, it's such good training. Like if you're responsible, I think we call them most responsible providers, family doctors, midwives, nurse practitioners. If you're responsible for someone's life, it is so humbling, right? You have to know your stuff. You have to I think it's helped with the decision making because sometimes you don't know if the decision you're making is the right decision. And I think there's two types of people, right? There's the people that know that and own that. And then there's the people that don't want to make the decision. And even in our training, we started with 30 students in the class and we graduated 11. And it's because every year it got more real and people were more humbled. And I think for entrepreneurship, you have to be comfortable with the uncertainty. You have to do your homework. You have to do the best that you can, but then you always know that there's some portion of that is going to not make sense in the long run. So I think being in the birth room, being in high stakes scenarios, being in major complications, scary stuff, your nervous system learns to hold it. And then you have to learn to come down off of it quickly. So if you have a setback in business, you have a setback in the clinical space, sure, you have to feel it, you have to like debrief it and think about it, but then you have to pick yourself back up and go again. And I think that doing that for 15 years and helping others do that makes stepping into entrepreneurship less scary.
You have developed a patent with birthing gown and medical devices. Let's say someone who has an idea, of course, in a clinical space, what would be the process look like from that idea to building a prototype, get it approved, and put it out in the market?
Yeah, it's a great question. It's a lot.
Sure.
There's a lot to do. So for me, essentially what happened was I had, again, done research because I had this problem that was driving me crazy, which is where a lot of ideas come from. So I had this problem that was driving me crazy. I sort of made a decision to sort of work on a solution instead of sitting in the problem. And I had this idea and I thought to myself, the idea is a garment. I'm not a fashion designer. I've never put anything from my mind into the real world and sold it before. So I felt like I had no idea what I was doing. So what I did was, which is what I always do, is write everything down, map it out, try to brain dump my ideas. And I do this in multiple spaces, but I sketched out, and I'm not an artist. So I have the original sketches of my idea based on the research. And I had this one colleague that I knew would tell me the truth. I knew she is Dr. DeVrier. I'll tell you who she is because she's incredible. She is an obstetrical colleague of mine. She deals with high risk pregnant patients. So I said, if I send her my idea and my research protocol idea, she's going to tell me for sure if it's worthwhile doing or not. So I sent it to her, and she wrote me back and said, I think this is great. I think I would absolutely love to help you with this. And that for me was exactly what I needed at the time to get myself out of the fear that I was going to embarrass myself or make something sort of not useful. So took the research protocol, and then I had to apply for ethics to do it. And the ethics board said, you know that you're a professor at the university, you need to work with the university on this. And I had no idea what the process was. So the long and the short of it was, if you have an idea, I would just start talking to people, not about the idea specifically, because I couldn't disclose the idea. And I'm glad that I asked enough questions at the beginning, because if I had done a conference presentation on it, or if I had publicly disclosed it, I wouldn't have been able to file for the patent. So somebody told me early on, thankfully, keep your idea quiet, get non-disclosure agreements set up for anybody that you talk to. And then I worked with the university, and I made a decision early on to partner with them. And people go both ways with this. Some people say, you shouldn't have done that. That's your idea, your invention. But I really felt that if I wanted to get this product in the hands of every woman giving birth in North America, having a institutional partner in the health space was going to be really good. It was going to be a good thing. So I agreed to partner with London Health Sciences Centre early on in Western. And then through that process, found my people. So the tech transfer office, people who are designed to help you take your idea and commercialize it. Without them, I wouldn't have anything of substance to offer. So for me, the journey was really figuring out things as I was going along, getting introduced to the community partners. Tech Alliance in London, Ontario, obviously is a huge partner here. BioNext at Western. So I was just figuring it out as I went while still working full time and raising babies. Who were the people that I needed? what was the process, and then looking to companies that were ahead of me. So there are companies here that have MedTech devices that are ahead of me, that were gracious with their time. So I had to just really think about, what are the resources that I have? Who do I need to tap? How do you leverage those resources? And then understand that it was just going to be confusing and difficult, and just to keep doing I always say 1% every day. Just do one thing every day.
I have one obvious question from the conversation. Isn't there always a second person in your initial idea to help you, or basically to validate it?
Yeah. Oh, yeah. Like you mean to see if your idea is going to if there's going to potentially be any product market fit?
Right.
Absolutely. So because the product came from the research, so I had asked the clinicians, and I had surveyed over 100 clinicians and over 200 patients.
Wow.
So I had asked them, and I asked them down to, if you were going to go to the operating room and you were told that you may not be able to do skin-to-skin contact, would you pay for a product that would do that? And 60% said yes, and 60% said yes, and they would be willing to pay $150 or more. So that alone I thought was incredible. And so I knew there was a need. The need was really validated by my long-term experience in researching clinical work. And then the clinicians also being able to echo that this was a gap that they wanted filled. In their surveys, they said, we don't always do skin to skin in all births. My patients request it the majority of the time. And 75% of them said they were unsatisfied with the current way they were being able to provide care. So I knew there was a gap for both. What I didn't know was all the research on how much money skin-to-skin contact in protecting someone's dignity could save the healthcare system. So that was a different research project. But so I knew through those initial conversations that there was something there. But obviously you don't really know until it's for sale and someone purchases it.
Right. So based on that conversation, let's say someone is having the idea.
Yeah.
The first step should be, if they are sharing with someone, to get the NDA.
Yeah, I would.
Just to protect the idea and the ownership. Following to that, get it patent if needed. And what would be the prototype process look like? Of course, your idea was more towards the garment industry, and you would ask someone like a designer or some kind of sort of those people who can design and basically stitch it together to make it a wearable gown. What would that look like for the med tech entrepreneurs or people building the medical devices with tech incorporated within that?
Yeah, and you're definitely correct in that you need to have, so a lot of times the person with the solution or the idea isn't the person that's going to build it, because they're not, maybe don't have that expertise. And if you do, that's great. For me, it took me 23 different designers. It took me a lot. And it was because everybody thought it should be just a simple thing to, this is a simple concept. But the barriers to entry, like there was so much in every measurement in that product, there's a reason for it. There's a reason why the shoulders are this wide. There's a reason why the waistline is here. There's the fastener, everything, every detail has a reason. And that reason is at the intersection, that answer we came up with is at the intersection of clinical requirements, how the patients are going to experience that product, and then how do you launder it in a system that has not been innovated in 30 years, right? So there's so many areas that were contradicting that I thought, well, if I do this, then somebody else would say, well, you can't do that because of this. So it took me a long time to figure out what's the product that I need to make that's going to de-risk and actually allow us to implement it. Because there's a lot of MedTech products, a lot of FemTech products that are beautiful. They're apps and software devices, and they're very VC friendly, and they're VC ready. They look stunning. They've got some product market fit, but then when you get to implementation, they're not built for clinicians. So clinicians are like, I don't even want to use this. So I had to de-risk that side of it. I had to build something clinicians would use. But 23 designers, it took me, finally I found my team out of New York, Susie Wakefield Designs. She's incredible. And I just had to keep going to find that. But there are companies you can hire. There's product development companies. There's some out of Toronto where if you have an idea and you need something built, you need a prototype built, you can contract that company. Where I think people will get hung up as an entrepreneur in the beginning is the money. So you want to file a patent. Well, patents range anywhere from $8,000 to $10,000. So again, I have an institutional partner. So I was really good at leveraging who I had resources with and how to get these things funded through research grants and non-dilutive funding. But I mean, that's so much work, right? To get to file the grants, get the money. And so part of the first few years was me figuring out how to do that. And then once you have the patent filed, then you have 12 to 18 months, if not 4 years, to figure out if you get it, right? Exactly. So we filed in the UK on purpose because the UK has a shorter timeline to do that global search. So we knew the UK would give us a quicker answer as to whether there was something here worth patenting. And we didn't patent the design. We made it a utility patent. So the way we use the product. So if you're thinking about building something, you're going to probably fear the money side of it. Like, oh, I want to build this thing, but oh my gosh, it's going to cost me $40,000 to get this company to build this for me. I think we need to not let that fear stop us and think about what are the resources we have, who's done this that's come before me, who can walk me through that. Because in hindsight, it was very simple. But at the time, it felt like a massive, how am I going to find 50K in a couple weeks, right?
Is there any government grants that you can access being as a woman? And before you answer that, I just want to share that if you have an idea, we are here to help you with PO24 technologies. We are going to build your MVP. What Meagan is talking about, finding a partner or finding a right company is very essential in your initial growth. And of course, to move forward and scale from that idea. So reach out to us.
There are lots of grants. There's more grants now, I think, than there's ever been for women or for equity-seeking groups. If you go on the government website, you'll find there's lots of different partners. A lot of times you need an investor on board to qualify for some of the bigger grants, but some of the banks have grants. RBC, Scotiabank often has grants for female entrepreneurs. Universities often have grants if you have a faculty status or a student on board. I really leveraged Western. Western's been very kind to me, Western University. So they always have running grants. They also have a pre-seed grant out right now that I've just applied for. So there are lots of grants. It's a bit of a hunt to find them. There are some government services that you can access that will walk you through what grants you are eligible for. So it's really just scouring the internet. There's also boot camps. So there's accelerator programs and investor readiness boot camps. There's lots of courses that will actually even stipend you money as part of entry that and won't take equity in your business. So that's the other piece, is thinking about not giving away your company up front, right? And leveraging the grants as much as possible before you start bringing on investors. But there's time that you have to take mapping that out. Like, how much money do you need, right? What's the goal? Where do you want to be by such and such a time? Figuring that out is a skill set and takes time too.
Totally agree. You talk a lot about empowering others. Was there a moment in your life when you felt least empowered?
Oh, yeah. Yeah, I would say that the point of time after I had my babies, if I'm being honest, it was such a different pace, I think, for any women who want to build, who are having children. Not everybody wants to have children, and that is totally fine. If you are somebody who wants to have children and you're an entrepreneur, it's a very humbling experience to take your nervous system from being in a hyper aroused state where you're building and creating and leading and running to a human that your hormones are all over the place. And for me, I felt that part of my identity, being an entrepreneur and being a leader and a clinician, was such a core part of my identity that being a mother, I had to make space for that. And that was really difficult for me. So I felt like my identity basically disassembled after the birth of my second child, with my broken leg and all the pieces. And I had to rebuild who I was, if that makes sense. And that was a
Sure.
very hard time for me.
How
'cause I
did you
wasn't
tackle that?
I sat in it. I think we talked about this before, but I had to get really it was so rare for me to sit and reflect on what I was building, what am I doing here? What matters to me? How do I want to show up in the world? And I would just be running A to B, birth to helping this person. And it was like nonstop. And then you have this child my values is to be a good mother. That was always part of my core values. So how do you show up and be a good mother, but then do all the things that you were doing before? It doesn't work. So I had to get really honest with myself about what mattered to me, how I was showing up. And I think honestly, at the time, my body was exhausted and it kind of did it for me. Like broke my leg, out of commission. All I had time for was babies and thoughts. And so going on that journey, it was a transformation in who I wanted to be, who I was. It gave me time to think. And then when I went back to work, that's when I had a stronger vision of like master's, gonna get to this, gonna do this. So I needed to give myself that time.
Right. Did you ever feel like your medical world shows you or you being presented as being too entrepreneurial, or the entrepreneur world presented you being as more clinical? And even being on top of that, being as a woman in a leadership role, does that make any difference?
That's a big question. There's a lot in there. I would say in terms of the clinical and the entrepreneur, like, do they compete? Like, are you asking me if those roles they do? They complement each other so well, though, and I think that's part of the reason why I can't give either of them up. Is this? I mean, imagine you're an entrepreneur with an idea or a bunch of ideas in an industry that you have a leadership role, credibility, and authority in. It opens so many doors, right? It's such an enabling part of my work. So I think an entrepreneurial mindset in healthcare is very valuable. When you get into decision-making rooms, you're listening to budgets, you're listening to people talk about where money's going and what matters. Being a clinician, I notice that perspective isn't always present in those discussions. We might be talking about money, like how much we're going to spend on an epidural kit, and talking about how expensive they are. And then having a clinician come in and say, with a business mindset, say, we're not trying to lower our epidural rate at all here. If you want an epidural to help with pain relief, absolutely. But there's lots of women that don't. But we don't offer them a big, strong alternative. So you're throwing money away, right? And so being a clinician and entrepreneur is like, I would almost say like a double threat, because you have the ability to inform on what matters, but you also have the ability to structure a business case in a way that allows you to make an impact and in a way others don't see, if that makes sense.
Absolutely.
So I think they're both very complementary. I wish I had learned more about business earlier. In terms of the women in leadership piece, I think being a woman in leadership it's a nice time to be a woman in leadership, because and I'm generalizing here, I can speak from my own experience. I think the hardest part is the journey you have to take to get there. Because if you're a woman in leadership and you're in a room that you don't feel welcome in, or maybe you are welcome, but you don't feel welcome, you don't get to show up in a way that really is authentically you. So when you realize that, wait a minute, I do know a lot about this. I have done this before. I do have something valuable to say, and I can lead people. Then it becomes really fun, because you stop worrying about whether what you say is going to be taken the wrong way, or if you're going to fit into the male-dominated space, which is changing. There's a lot of more diversity now, but I love being a woman in leadership. I think we bring so much to the table, and we complement our male colleagues really well, and we build relationships beautifully. And that's always been my focus since I was early career, like build those relationships. because it's hard to call in a favor when you don't have a relationship, and the amount of stuff I can get done. My colleague made fun of me a couple of weeks ago. She said, we went to a training together with all of the department heads, and she said, man, watching you, like 2 hours in the morning, you got so many yeses to things that you need. I said, well, they're colleagues now, right? Like we support each other. But if I didn't have those relationships, like it's really hard to lead and make an impact at scale. And in my case, disrupt an industry. If you want to disrupt an industry and you want to change the way that we provide care in a space, it's going to take a lot of people, and it's going to take a lot of expertise, and it's going to take somebody who cannot stand up and be worried about what people think. That part was probably the hardest part of my journey so far.
Right. You mentioned male-dominant industry. Was there any moment where people tried to put you in a box?
All the time. Yeah. I think that's been my whole life. And myself too, trying to sort of figure out, like we talked about this earlier off camera, who am I? What am I doing here? What's the purpose? What's my purpose? And I think I spent a lot of my life trying to put myself in a box, and am I this or am I that? And I think when you're a creative, you're good at a lot of things, and you kind of try to figure out just because I'm good at a lot of things doesn't mean that I should do all the things. So being put in a box, there was a period in my life where I was a clinician and that was all that I did. And then I went into research and I was like, okay, am I a researcher now, or am I a clinical researcher? And then into health leadership. Okay, well, am I just doing health leadership now? So, and all the time I get told I'm a lot, right? Like, you have a lot of ideas. Your ideas are too big. That's going to be a lot of work. And I get it. I understand that piece of it. But I think I'm a very multidimensional person. A lot of women are, a lot of people are. And I think I spent a lot of my life trying not to be multidimensional, and then realized that I kind of just am. And that's okay if I want to do 50,000 things. And people will often tell you to build one thing at a time. And I spent so many years feeling bad that I was always building. I was building in research. I was building in home. I would be painting, my living room. And my husband would say, why are you painting the living room? It's like, because I just love the space, so I'm always creating. And I think once I stopped trying to put myself in a box and I accepted that other people always will, it doesn't mean I have to do anything about it. I just let people think I am what I am, and I just keep doing what I'm doing.
Love that. You also serve as the Ontario site lead for Justice and Equity Perinatal Services, or JEPS hub. Yeah. What's happening in women's health space?
Yeah, so the JEPS hub, it plays into the Canadian strategy. So the Justice and Equity and Perinatal Services Hub is a large research grant out of Canadian Institutes of Health Research. So CIHR is a big grant agency. They fund large grants across the country every year. So the JEPS Hub work is focused on implementing tools that were created by this incredible team out of University of British Columbia. Dr. Saraswati Vedam is their lead researcher. She's my hero. I adore her. And she has a whole body of work looking at how women are treated in labor and birth. And she's developed all these tools, and her focus is on mistreatment and how we can go into hospitals and help create safer birth experiences. So our work aligns incredibly. So she reached out a few years ago and said, does your team want to partner on this grant? We want to implement a tool in the hospitals. And this tool will actually help the hospitals grade themselves on how well they show up in these different domains. So the long and the short of it is I work with them helping hospitals implement this tool and figuring out where are we showing up in the right ways and where are we not? And how do we make sure that if we're collecting data, that race is accounted for. It's hard to build solutions for people if you don't actually understand what the problem is. So that work is part of hubs across the country. So CIHR funded multiple hubs. So there's one in British Columbia, there's one in Halifax, in Quebec. And these hubs are all working on aspects of women's health that has for a long time been ignored. So my work with them is really just trying to support hospitals, and we're going to be starting that work more soon, grading themselves, change policy so that we can actually look at mistreatment, look at dignity, and give women, especially women of color, the experiences that they deserve, because their morbidity is higher, their risks are higher. And sadly, that's a lot to do with structural and systemic racism.
Interesting.
Mm-hmm.
I have a question. How are you able to do so many things? You are department head of midwifery at London Health Sciences. You have your own startup, your own company, Revara Care.
Mm-hmm.
Being as a professor at Western University, not just one, Western University and McMaster University, being one of in the industry in the entire province, Ontario. How, do you have 48 hours in a day?
Yeah, I wish. I really wish. Well, I would say all those roles are small and some are big. So some of them are, time commitments are much smaller. I think obviously my husband is a huge part of this. I wouldn't have been able to be a midwife if I didn't have my husband, because he's the stable 9-to-5 person. But I think it really comes down to, people always talk about balance. People always talk about, making sure everything's in balance. And I always say that for me, it's less about balance and it's more about alignment. Like, is what I'm working on in alignment with the vision that I have for my life and the people that I want to create and serve? That might sound silly to some people, but it actually helps me a lot figure out what is, I'm sure you've heard of the concept of signal versus noise. Have you heard of that concept? So thinking about day to day, so tactically, what do? I try to stay as organized as possible. I leverage technology as much as possible. If I can't see everything that I'm doing, I get really overwhelmed. So I have to track everything in terms of what are the projects that are ongoing. And then what I've done strategically, I think is just pretty typical of busy people, is build as many teams as possible. So my department team, I have incredible midwives working on tackling major issues that we've been dealing with. So instead of me feeling like I need to do all the things, I enable and support my team to do those things. And I'm strategic about who I tap for those things. And then in the research world, we have our research team that we divide up workload, and we're hiring right now for that. So I'm trying to build those teams to help support the work, obviously, in those areas. The startup work is very much just me right now, and fractional work, but I'm so part of that build that I can't pull myself out in the same way. But I leverage technology. And then I always think to myself, okay, if I have this to do and this to do, what is the thing that's going to be most aligned with where I'm going? Sometimes I don't get the luxury and I have to do the things I don't want to do. And I think also growing over 20 years, you get really good at doing things. Like, you get good at grant writing, you get good at leading, you get good at policy. So the more reps I've put in, I'm just at a point in my life where I can handle a lot of balls in the air because I've been doing it for so long. I wish there was a magic pill that you could just, but I think hire good talent and give yourself grace, and don't lose yourself in the process of it. Get some sleep, which is contradictory to the startup culture.
Yes. Do you read books?
I do read books, yes.
Which one are you reading now?
I'm reading 3 books right now.
Wow.
Because I love audiobooks. You know what? I go back to this book all the time, but I'm reading the Personal MBA just because I don't have an MBA, and there's some helpful things in there. But the book that I'm reading right now that I've gone back to is Dare to Lead by Brene Brown, just because we're doing some focused leadership work on our midwifery team right now. So I always just love to refresh on those topics. And Profit First is the book that I'm halfway through right now, because I'm learning business on my own and all the things that you need to do to build a company.
Do you have any book suggestion for the midwifery industry,
Oh my
or
gosh.
a book for, let's say, a woman who is going through the birthing stage?
Yeah. Oh my gosh. There's so many. I mean, a lot of the client-facing books are pretty similar. There's a lot of standard books for when you're pregnant. For midwives, like, I just keep telling them, they're probably so sick of hearing it, to invest in their leadership skill set. Like, I wish that I could go back and learn leadership first, because it's a modular approach to building that skill set, and everything I do is predicated on how well I can lead in that room. So I've been investing my own team in leadership. I've hired someone to come in and teach it, because if you can't, in a system, communicate, be assertive, set a boundary, design terms of reference and like a strategy, then it's not as fun. So I get a lot of midwives and clinicians come to me with problems on the front line, conflict and debates, and it's a lot of it comes from the fact that they don't know how to communicate what they're trying to say in a way that's going to be amicable. So they end up fighting, and then I end up having to address it and deal with it. So leadership is my go-to all the time. Anything which is why I'm probably reading Dare to Lead again. But I think that's the number one skill set across all industries, across all roles, that if I was to start with, that would be the one I would encourage.
For someone listening to this podcast, we talk a lot about high performance life, because you cannot have balance across different stages, different areas of your life. And that was the whole reason of outgrowing this podcast.
Yes.
So let's say someone listening to this podcast, a woman specifically, a high performance woman like you, keeping that professional fire alive and going through a stage where starting a life or starting a family, what would be that look like, and how do we still maintain the same pace going through this changes in the major changes in the life?
I think you often can't maintain the same pace. I think that's part of it. And I think when you try to, that's where you get the most discomfort. And I think any major life transition, right? So you've got a baby, or you've got aging parents, or a divorce, like it could be anything. There's this, again, moment where you have to pause and reflect at what matters to you and how you want, your strategy changes, right? I think as a woman, there's so many things, but I think we often take responsibility for things we don't need to. We overgive. We care a lot about what people think. And I have a daughter, she's 13, and we had this exact conversation last night about something she had to go to today, and she was exhausted. And she said, I really don't want to go, but I'm afraid this person's going to be mad and this person's going to be mad. And it really was a low stakes thing. It wasn't a high stakes thing. So I said to her, you have to make the decision, because are you going to care what people think, or are you going to prioritize yourself? Because you need to sleep. You're exhausted. And she was so wrestling with that decision. But I said, I want you to learn this now before you're 35, like I did. It took me so long to realize that the sky wasn't going to fall if I just said no to things. If I didn't take responsibility, I just kept trying to keep the peace all the time. And I think you can't keep the peace all the time. So I think when you're having a baby or going through a life circumstance, things are going to shift. But I think you have to be really clear on where you are not prioritizing yourself. So if you're an overgiver and you're going to take responsibility for everyone's stuff, you're going to be in that same spiral all the time, versus saying, I just had a baby. I'm not going to be able to do this for a little while. I've hired this person to do it. No, I'm not available, or I'm only available to you know what I mean? Like setting that structure. And then when people come to me and say, well, I can't do that because, I don't have this money and I don't have these resources, I just say, sure, there's always a third door. There's always another way. And so where are you showing up? Because it all comes from you. Where are you not setting a boundary? Right. And as women, and midwifery is predominantly female led, midwives are usually mostly women. And half of my job is just talking to them about this. It's mentoring them to say, well, you could have done it this way. And they say, well, no, I couldn't have. I said, well, technically you could have. Challenging them to think of things differently and set those boundaries, because it holds us back. We don't show up in rooms. We don't use our voice in the same way. We don't ask for things. Oh my goodness. In pregnancy, women pregnant, most of my visits were talking to them about that stuff. Them saying, I'm not happy about this. I'm not happy about this. And I would say, well, what are you going to do about it? And what do you want? And they would say, what do you mean? What do I want? I'd say, you just told me everything you didn't want. What are you actually aiming at? If you don't know what you're aiming at, you're never going to get it. You're not going to know what to ask for.
Exactly.
So that's a long-winded way of saying, women are usually playing small. They're not usually asking for big things. A lot of us do. But when we learn that if we ask for things, we often get them, we can often take something and make it 10x it. We're creators. We're really good at that. When we figure that out, it's pretty awesome. It's pretty cool.
What are those opinions of midwifery that are mostly taken misunderstood? Or how can we make this world better so that those voices are voiced loud enough or heard enough?
Oh my gosh, it's such a good question. So a lot of my role is spent debunking the myths about midwives. And it's really frustrating because midwifery is, the research done on midwives is incredible. Like the outcomes are great. The clinical outcomes are great in Canada. Midwives are a part of the healthcare system here. So we have a built-in structure for it to be a safe profession. So not only do we provide good care, the research would show that we provide exceptional care. And there was a study done a couple of years ago by Dr. Stahl out of British Columbia. And she looked at, because the logic was always sort of before, people would say, well, midwives have low risk patients, so of course their outcomes are better. But what she did was she took 2 samples of OB obstetrical patients and midwifery patients, and she compared them with the same risk profile. And the outcomes were still better. And it's not about who's better. It's not about, are midwives better than OBs or OBs better than midwives? They're different roles. We get caught in that discussion and argument about who is better. What we should be doing is talking about how we can work together to serve as many women as possible. That should be the conversation. So my job is spent talking to people all the time that midwives are real, we're here, we're a regulated health profession. The problem that I have is that I think midwifery in the early 20th century was outed by medicine, and we dismantled midwifery in the way that it was known. And now it's trying to come back into the system. The problem is that midwifery itself as a model of care is wonderful, but there's something about the branding of midwifery that people cannot seem to reconcile with. And I'll give you an example. I was at a conference 2 weeks ago, and in the conference, there was a panel discussion, and one of the physicians, who's incredible, said, imagine what women's health would be like if we had mom care and baby care done at the same time in postpartum. Imagine we could see them both at the same time, and we could do their blood pressures. And she basically described the midwifery model of care. And I thought to myself, we already have that, but we're not funding it. We're not scaling it. Midwifery works. And if you ask my physician colleagues, they'll tell you the same thing. They'll say, yeah, like we love when you guys are involved because women are happier and care is more comprehensive. So there's a lot of myths about midwives. If midwifery was a model of care that every woman, our wait lists are 1,000 patients long. They're so long. If we invested in midwifery, I do think that you would actually see healthier postpartum families. You would see women back in the workplace more. They'd have reduced mental health conditions. There would be so much value that would come from that. And it's not because it's midwifery partly, but it's because our model of care, our approach is we have more time. We're educating you. I will crawl into bed with them, like literally at their house. They'll be in bed postpartum crying, and I will show up with my gear and I'll just sit in their bed and be like, let me just weigh your baby here. It's the most beautiful model. But for whatever reason, it's not a priority right now. And that's a lot of the work that I do is advocating for that.
Right. You are a pillar of health scene, either being the head at the London Health Sciences or being the only one in Ontario in your industry, leading the Ontario site, lead JEPS hub that we talked about. What's the big vision, the top 1% vision that you have for the industry, or let's say, what's the biggest goal?
I would love to change the way that we provide care to women in labor and birth. That's one example. And what I mean by that is change the standard. So the way we approach women, whether it's with the products that we create, we give clinicians products that they can use to close that gap. Because what we have right now is women asking for one thing and clinicians not being able to provide it because we just don't have a mechanism for it yet. Whether that's create more time, women want more education. So the company, Revara Care, the company itself is really designed to come up with those solutions. And again, we have 3 solutions so far. One of them will be launched sort of the end of this year. It's a lofty goal, but the goal is to actually come up with a mechanism for these clinicians to show up in a different way so that they can meet them, close that gap between the patient and the clinician where there's conflict, change that to say, okay, we've created structures now, whether that's policy, whether that's consulting work, coming in and talking to leaders about why there's so much conflict. Obstetrics and gynecology is one of the most litigious areas of medicine because if you hurt someone's baby, or if women are really upset and feel traumatized, who do you think they're going to get angry at? They get angry at their clinicians. The clinicians are in a situation where they cannot always provide them with what's recommended. So I'm trying to close that gap in a few different ways. So my goal is to disrupt an industry, as lofty as it sounds.
As we are reaching to the end of the podcast, I always ask this question to all my guests. What a successful day look like for you, Meagan?
A successful day for me looks like getting all the things on my list done, which is never the case. But I think a successful day for me means that the people that I serve, I was able to provide value for them in some way, whether that's a 5-minute phone call because they were upset about something that I could help them with, or whether that was finishing a policy change or some sort of structure that's going to make lives better for everybody. Building relationships is a successful day. I love meeting people. And then ending the day with some sort of time with my family. Like my kids love to crawl in bed with me and talk about business or their own ideas, sketching. They love to sketch. So we do a lot of sketching. So yeah, a mix of like doing what I love, creating and serving, and then being able to end the day with my kids.
Awesome.
And my family.
Awesome. This was amazing.
Thank you.
Thank you very much for being here, Meagan. I truly appreciate your time and everything that you're doing for the industry. Thank you.
Thanks for having me.
I'm so humbled to meet such a kind of person today who is at the center of leadership where those high-stake decisions are made, and in a clinical setting where she takes those decisions of life and death along at the intersection of entrepreneurship where she is building her own business with a patent medical device and sharing and empowering the entire world. I'm sure you gained a valuable insights and a different perspective on how you handle things, and specifically, as I mentioned earlier, the ones who are at the epicenter of the problem are the best one to solve it. If you found a value from this podcast, please consider it sharing and please subscribe the channel. Until then, keep figuring it out, and I'll see you in the next one.